Good evening, class. My name is Aaron Johnson. I will be presenting to you today my medical nutrition therapy for end-stage renal disease and hemodialysis. This is a case study analysis brought to you by Frenius Kidney Care at West Pettigrew. And I did my practicum actually with Professor Neubauer of North Carolina Central. So I'd like to thank him for giving me the information for this case study. All right, so let's talk about the prevalence of end-stage renal disease. So nearly 750,000 patients in the United States and an estimated of 2 million patients worldwide are affected by end-stage renal disease. End-stage renal disease is increasing in the United States by 5% each year. So this is a growing problem that we're having. And we're going to get to the root of the problem, the cause of the problem. More than 100,000 patients in the United States are on kidney transplant lists, but last year there were just 21,000 donor organs available for transplant. The need for donor kidneys in the United States is rising 8% per year. So based off of this information that we have right now, you can see that the demand far exceeds the supply. African Americans are 3.5 times more likely to have end-stage renal disease, and Native Americans are 1.5 times more likely to have end-stage renal disease. This is mainly due to the demographics of that group. They are most of the time, or the lifestyle that some of them live is not a very healthy lifestyle, and you're gonna see with our patient that we have, who was actually a Native American, the cause behind her issues as well. The etiology of end-stage renal disease, the risk factors: diabetes with poor blood sugar control. Diabetes actually is 80% the cause behind end-stage renal disease. The reason why is your kidneys are very fragile organs. When you have high blood sugar, that really damages those intricate veins and arteries in the kidney. The kidney disease that affects the glomeruli, which are the structures in the kidneys that filter waste from the blood. So like little tiny venous structures in the vein. As I said, your kidneys are very, very fragile. And what these do is they filter the waste from the blood. Also, high blood pressure. High blood pressure can damage those intricate pathways in the kidneys as well. African American descent, that's another risk factor. And older age. As you know, when you get older, your body does not function as it did when it's younger. So it's very important to take care of your body while it's young, so that your chances of having this disease is smaller and smaller. The survival rate of ESRD. After 1 year of treatment, those on dialysis have a 20 to 25% mortality rate. And then the 5-year survival rate is 35%. So as you can see, the life expectancy on hemodialysis isn't very great. Persons who receive transplant have a 3% mortality rate after 5 years, and that's a very small margin as well. 3% mortality rate after 5 years. We're going to get to that too. So let's talk about hemodialysis. You heard me mention hemodialysis in the previous slide. Basically, what dialysis is, you have a mechanical device that filters the blood. It acts as an artificial kidney. And as you see, it's defined as that blood is removed and filtered through the man-made filter called a dialyzer that works as an artificial kidney. Now, hemodialysis, it works with filtering out the blood, but it never really does a better job than your kidneys will always do a better job than a dialysis machine. There are 3 access points in hemodialysis. We have the arteriovenous fistula, we have the AV graft, and we have the central venous catheter. So let's talk about the first one. The AV fistula, as you see in this picture on the left, it takes your artery and reattaches it to the vein, making one channel for the vein and the artery, so they're both connected. This is the most popular form of hemodialysis because it's the safest and it's the cleanest. Your chances of infection are small, your chances of blood clotting are small. This is the most popular form of hemodialysis that you can get right here. Let's talk about the AV graft. So the AV graft does the exact same thing. It has the exact same function and purpose as the AV fistula, but the only difference is this U-shaped tube that you see here. It's an indirect way of attaching the artery to the vein. This isn't as popular as the AV fistula because their chances of infection are greater. So this isn't as popular as the AV fistula. Over here we have the HD catheter. So let's look at this diagram right here. The HD catheter, now this is the least popular of all of the hemodialysis functions. You have the incision where this vein is right here. It really goes mainly into your neck. It can go in your groin area, but most of the time this is inserted into a vein in your neck. As you know, that is the least popular form to receive hemodialysis from, and this is only used in emergency purposes. Now let's talk about the 5 stages of chronic kidney disease. So this chart, it very, very professionally lists the 5 stages of kidney disease. Let's talk about this middle section right here, the glomerular filtration rate. We're going to call it GFR. So that the GFR is basically a test to that really test the proficiency of your kidneys to filtrate your blood. When your kidneys can't really really filter your blood at its highest level, you have a lower GFR. When you have a normal GFR, when it can really filter out blood like almost perfectly. So the first one, stage 1 kidney disease, you experience it's really normal. If you have a GFR more than 90%, that is good. 90% or higher is really good. Nothing really too noticeable. Stage 2, kidney damage and mild decrease in GFR. So that's going down. You're now at a 60 to 88% GFR. Stage 3, moderate decrease in GFR. We're down to 30 to 59%. And look, 70% to 77.5% of your kidneys are damaged. Stage 4, severe decrease in GFR. We also have a GFR of 15% to 29%. We also have a kidney function deterioration of 77.5 to 85%. And then finally, stage 5 kidney failure. This is when we call it end-stage renal disease. And when you're at that stage 5 mark, that's when you're going on dialysis, and we'll put you on the waiting list for the kidney transplant, if we can or if it's needed. Appropriate nutrition for patients with end-stage renal disease. So most people with dialysis, they gotta really watch their potassium levels, their phosphorus levels, their fluid levels, and their sodium levels. Potassium levels, because potassium is it's a very necessary mineral in your body. It's an electrolyte. Your muscles need it. Your heart needs it for contraction. But if you get too little potassium, that can cause muscle cramps, and too much can cause a heart attack. Phosphorus levels, you want to watch the phosphorus levels as well, because too much can lead to brittle bones. And when we start to notice the buildup of phosphorus in your blood, then that's when we will try out phosphorus binders, and that acts as a magnet that'll attract all that phosphorus, and then once it's attracted to the phosphorus binder, you can excrete that later on. You want to watch the fluids as well, because too much fluid can cause high blood pressure on your arteries, the compression of your arteries, and that can also cause swelling, trouble breathing, and heart failure. And sodium, because sodium attracts water, and because it attracts water, your blood pressure is naturally going to rise with that compression in that water that is compressing on your arteries as well. So your blood pressure is going to rise, and as I said, sodium contains water. Extent of malnutrition in end-stage renal disease. One research work reported albumin concentrations of less than 3.7 grams per deciliter in 25% of their patient population, which included more than 12,000 hemodialysis patients. This study is basically saying people on hemodialysis are experiencing low protein levels. That's because when hemodialysis cleans that blood, it takes out a lot of stuff that your body needs. Like I said, it doesn't do a better job than your kidneys, but we notice that patients on hemodialysis, they have lower levels of protein as well. So for the case study, our patient was Miss Joaquin. She was diagnosed with impaired renal function with incidence of hypertension and diabetes. And this is interesting because she's a 26-year-old young female. She's Indian descent. She's married with one child. She has both her mother and father. This has to do with her family history. Both her mother and father have diabetes as well. She works the hours of 9 a.m. to 5 p.m. as an occupation secretary, which that involves a lot of sitting as well. Sedentary lifestyle is not conducive to a healthy lifestyle. Her past medical history, as you know, she has type 2 diabetes. She was poorly compliant with her diabetes medication, and which leads her to have high blood glucose levels, which we're going to talk about. She has no previous surgeries outside of her child that she had. She has no known allergies. She has ceased or stopped her hypoglycemic agent. As I said before, she has higher blood glucose than normal. She never filed for anti-hypertension prescription, and that is why we're seeing a correlation in her high blood pressure levels. And she has a declining GFR, which leads us to the end-stage renal disease diagnosis, and she has high blood pressure because she's not adhering to her hypertension medication, anti-hypertension medication. So admitting diagnosis and events leading to admission. Her medical history, she has progressive decomposition in her renal function, has been documented by declining GFR, her increasing creatinine and urea concentration, her elevated serum phosphate. So let's look at this phosphate level. She has elevated phosphate level. That means her kidneys aren't able to process that phosphorus out. She's getting high phosphorus levels, and we're going to look at putting a phosphorus binder in there so that we can lower those levels as well. The second point is she admitted for placement of AV fistula to begin hemodialysis treatment. Remember, the AV fistula is the safest way you can administer the hemodialysis treatment. And for onset disease, she is diagnosed with impaired renal function 2 years ago. I remember her case that 2 years ago she had, she was diagnosed with chronic kidney disease. But now she's developed end-stage renal disease. So acute symptoms have developed over the last 2 weeks. It looks like, yeah, so these are her lab values to note. Her potassium was high, her phosphorus levels were high, her magnesium was high, and her glucose, as I said, her glucose levels were high as well. She's not adhering to her diabetes medication. Her blood urea nitrogen levels were high. She has high nitrogen in her blood. That is another sign for end-stage renal disease or chronic kidney disease too. So she had high creatinine levels and high cholesterol with low sodium levels, high chloride levels, and a total CO2 of 20. So we took her measurement. Her height is 5 feet 0 inches. Her current weight is 170 pounds, but her BMI is 33.2. This puts her in class 2 obesity. It's not a healthy BMI. So you're going to see how her lifestyle and her diet plays into it next. Medical treatment plan. Her surgical placement of AV graft. We're going to do the AV graft. We're going to administer erythropoietin 3 units kilograms. Now, erythropoietin is a natural hormone that your kidneys make, and basically what this hormone does, it synthesizes red blood cells. It helps create red blood cells. It helps in that process. And so when you have a low erythropoietin level, then you have a low blood count level. So there's a correlation in that. We're going to monitor her vitamin and mineral supplements. We're going to give her more, but we got to monitor that too, because you don't want to administer too much phosphorus, too much potassium, too much minerals that can accumulate in the blood. Her Hectoral, we're going to administer Hectoral. This is actually going to monitor her parathyroid hormone. We're going to get her 1.2 grams of protein per kilogram, because with hemodialysis, that's going to take a lot of protein out of the blood, and she's going to need this protein. The glucophage, 850 milligrams, we're going to prescribe that to her twice a day. This is going to keep her diabetes under control, lower that blood glucose level, and we're going to administer a stool softener to help her go to the bathroom as well. All right, nutritional evaluation and therapy. So this is going to pinpoint what she's been eating, her diet history, and this is going to tie a lot of things together and it's going to make a whole lot more sense now. So for breakfast, she ate a bowl of cold. She usually eats a bowl of cold cereal, bread or fried potatoes. She also has a fried egg. I'll get to that egg in a minute. For lunch, she has a bologna sandwich, potato chips, Coke, and for dinner, she has chopped meat, fried potatoes, and for snacks, she has crackers and peanut butter. So, first of all, let's point out the things that we really noticed. We did notice that she had high carbohydrate levels, such as cereal, containing high carbohydrate foods containing like cereal, bread, fried potatoes, sandwich bread, potato chips, Coke. Those are going to raise your blood glucose levels. So that is not a healthy diet. I want to point out the fried egg and the chopped meat. So you might say, well, you're getting protein from that the fried egg and the chopped meat, but on the other hand, animal protein correlates with phosphorus because all animal protein has phosphorus in it. We all have phosphorus in our bodies, even animals do too. So the fried egg and the chopped meat, we want to monitor that because that can increase phosphorus levels as well. Her calorie breakdown, she consumed 240 calories total. Carbs are at 220 initially. Protein was 75 grams. Fat were 150 grams. Sodium was 2,330 milligrams. We had to cut that down. So now her new calorie needs were 1,350 to 1,570. We had to cut that down. Her carbohydrate, we had to cut that to 150 grams, and her protein, we cut that to 50 grams. Her fat is 37 grams, and we cut her sodium levels down by 330 milligrams. So now it is at 2,000 milligrams. All right, nutrition, evaluation, and therapy. So her assessment, this is what we assess. She with the BMI of 33, she was an obese patient. She had high glucose levels. She had high cholesterol, high blood urea nitrogen, and she had low GFR. She had weight gain and edema in her extremities, muscle cramps, and inability to urinate, nausea and vomiting as well. She was diagnosed with obesity and also impaired renal function. For a PES statement, obese weight status as relates to BMI of 33.2 as evidenced by poor nutrition habits, not following nutrition plan, and shortness of breath and weight gain. She also had high levels of carbohydrate intake related to lab glucose levels of 282 as evidenced by not taking hypoglycemic agent, an excessive consumption of simple sugars and bread, and failure to follow a nutrition diet plan, as you saw in her previous unhealthy diet. Intervention, what are we going to do? Gradually decrease glucose levels. Monitoring and evaluation. What are we going to monitor? What are we going to evaluate? Monitor lab values. We're going to monitor fluid levels. We're going to monitor carbohydrate intake, and we're going to monitor BMI. We're going to get that BMI down lower. Now, her new diet plan. Reduce alcohol intake. That can be alcohol and kidney. Alcohol is horrible on kidneys. We're going to reduce overall caloric intake. We're going to use type 2 diabetes plan to monitor blood glucose levels, get her blood glucose levels down lower. We're going to reduce carbohydrate intake overall with each meal and control phosphorus serum levels with a phosphorus binder. The MNT goals, we're going to reduce weight, which will also reduce the BMI, reduce carbohydrate intake, monitor water intake, and increase physical activity. Nutrition, evaluation, and therapy. Methods and materials used. Importance of monitoring sodium intake and fluid intake. Importance of fruits and vegetables in the daily diet. You also want to monitor fruits and vegetables because fruits and vegetables contain water. You also want to watch out for the fruits and vegetables and monitor those. Understanding carbohydrates in the diet. Understanding of glucose control and explanation of weight loss goal. Have a doctor explain to her what chronic kidney disease is and how it leads to kidney transplants and why she needs to take hypoglycemic agent and antihypertensive medication. Also, we're gonna have the doctor explain to her the end-stage renal disease and the process that we need, or the steps that we need to take to take care of that. Nutrition evaluation therapy. So progression of nutrition management. Carbohydrates, we looked at her glucose labs, we looked at her hemocrit labs, her fats, or her cholesterol, her proteins, end-stage renal disease. We looked at her GFR, her sodium, potassium, phosphorus, and for evaluation of dietary treatment, her diet recall, we looked at that, and her lab values update, follow-up post-treatment, evaluation of weight status, and dehydration. So that's what we're going to evaluate as well. Referrals to case studies outside sources. We used the Durham Nephrology Associates, the Duke University Hospital, and the National Kidney Foundation. These had great information. And the case study prognosis for Miss Hakim. Her transplant therapy is needed. She needs transplant therapy. She is diagnosed, as some of you can put together, she was diagnosed with end-stage renal failure, and her past medical history is type 2 diabetes, And if the disease progresses, this can lead to, and is left unchecked, this can lead to cardiovascular disease. So conclusion, what do we conclude from everything? Patient mostly consumed high carbohydrate, such as cold cereal, bread, potatoes for breakfast, processed foods like bologna sandwiches, potato chips, and Coke for lunch, chopped meat and fries, potatoes for dinner, which are high in phosphorus. The meat was high in phosphorus. Crackers and peanut butter for snacks. Peanut butter is high in fat. Her blood pressure was 220/80, which is one of the factors that led to, which because it was left unchecked and she wasn't taking her antihypertensive medication, led to her end-stage renal function. And description of her abdominal appearance, she was round and obese with a BMI of 33. She had type 2 diabetes. Hypertension may lead to chronic kidney disease, and if left untreated, it can develop into end-stage renal failure. So we've already passed the chronic kidney disease. We are in the end-stage renal failure right now. These are the references that are used. All right. So thank you for viewing my presentation. Have a great day, and tell me what you learned later on. Thank you.